Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Thanks everyone for joining us today. Would like to welcome Dr. Shrisha Danreddy back to ECHO to do another talk. Shrisha is going to review some of the treatment abstracts from the recent CROI conference, and I'll turn it over to Shrisha.
Great, thanks. I think for those of you who tune into our ACC for Seattle, these will be very, very familiar since they're the exact same slides. But for those of you who didn't, because I know you all are very busy, so I'm going to highlight the treatment and cure aspect of the conference. And as you heard from previous talks earlier in the past couple of weeks about the CROI updates, there wasn't a whole lot about treatment actually. There was a lot more on prevention and a lot more on hepatitis C. As well as some metabolic complications and things like that, but not so much on treatment as there had been in years past, except for one highlight, which I'll talk about. And then Bob, actually, Harrington, who you all know as well, is very interested in the cure studies that were being done, and he thought one was very fascinating and wanted me to highlight that one as well. Mainly in terms of treatment, one big thing to talk about, and we've brought it up at many an ECHO session in terms of all waiting, holding our breath for TAF, which is going to revolutionize our treatment strategies, particularly for patients who have problems with renal insufficiency, hopefully. And so I'll talk a little bit about the efficacy data and toxicity data, and it's mainly two large studies, Gilead studies that were presented. And then the cure, something that Bob brought up, which is the immunoprophylaxis by gene transfer. And this is kind of a way to bypass the vaccine route, which has not been that successful. So TAF, is it worth all the hype that we've given it? So what is TAF and why is it different from TDF, which is what we currently use and is co-formulated in many of our medications that we use? So the active drug is tenofovir. It comes as TDF, which gets converted to tenofovir in the plasma, and then it goes intracellularly and where it does its job. TAF is different in that it isn't converted to the active drug tenofovir in the plasma. It's actually converted intracellularly to the active drug, which means that potentially the theory is that you would have less systemic blood levels of the drug and potentially less toxicity, and achieving that same high intracellular level so that you have high antiviral activity. Tenofovir alone of itself is actually not absorbed readily and isn't effective in the oral route. So we know that tenofovir, or TDF actually, causes significant renal and bone toxicity. TDF, which is usually at the 300 milligram dose, we know from previous studies, phase 2 studies, is equivalent to TAF, about 25 milligrams. There's about 90% lower circulating plasma tenofovir levels with TAF than there are with TDF. And this is data from a phase 2 study that found that there was also comparable efficacy and less renal and bone effects. So the Gilead studies that were presented at CROI this year are actually two large studies, phase 3, randomized double-blind, double dummy, and for those of you who don't know, they get both drugs, or it looks like they're getting both drugs, but one is a placebo and one is active, and active controlled studies. The endpoints, the study design were the same for the two. The only differences were the locations. So GS104, it was in North America, Europe, and Asia. GS111 was in North America, Europe, and Latin America. Primary endpoints were virologic suppression, or proportion of patients less than with a viral load less than 50. And then this is all week 48 data, but the safety endpoints that were evaluated were serum creatinine, proteinuria by a number of measures, which I'll show you, hip bone mineral density, and spine bone mineral density. You had to be treatment naive, so that's important to note. Viral load greater than 1,000, and eGFR greater than or equal to 50. So still not inclusive of a lot of our patients where we would think about using TAF instead of TDF. The regimen otherwise was elvitegravir, cobicistat, and emtricitabine as the other drugs in the regimen, and that's either, we know as that's co-formulated as Stribild versus substituting the TDF for TAF. There were about a little over 800 patients, 800, 900 patients in each group, and they were randomized 1-to-1. What they pointed out in the study is that they were extremely well matched, I think is how they put it. The groups were very, very similar in terms of sex, age, median age, race distribution, the percentage who had a high viral load greater than 100,000, the percentage who have a low CD4 count, and also the median EGFR and the percent with baseline proteinuria. The reason I put this slide in is because I just wanted to comment that so many people were on treatment at that 48-week endpoint, and this, compares to other studies which don't show this remarkable of a stay-in rate, essentially, or a low dropout rate. 95% remained on treatment in the TAF arm, and 92% remained on treatment in the Stribild arm. So really telling us that it's pretty well tolerated, and if there were side effects, it didn't lead to discontinuation of the drug. So in terms of efficacy, TAF is non-inferior to TDF. Purple is the TAF arm, and orange is the TDF arm. You see 92 to 90% efficacy rates in terms of that proportion who are virologically suppressed, and less than 50. Low rates of failure, similar in both groups. And then when you looked at it by viral load greater than 100,000, which we are concerned about certain regimens that we use, it was actually pretty comparable with both arms, the Stribild arm and the TAF arm. One thing that was interesting to note, although probably not very clinically significant, is that the TAF arm was associated with a significantly greater increase in CD4 counts, as you can see here, 211 versus 181 in terms of the median change from baseline. Even though that's statistically significant, I don't know if we would all jump up and down about that. Laboratory abnormalities, what's remarkable here, these are any grade 3 or 4, is that there's nothing new that comes out with TAF that we didn't already know with TDF. There's not any new metabolic complications, no new liver toxicity that we're seeing, nothing that really jumps out as being more seriously harmful than TDF. Again, similar with the adverse events that patients reported, and this is all grades. Number 1 on the list is diarrhea, and that's not shocking, likely due to the cobicistat that's in the regimen as opposed to TAF or TDF, and you can see it's similar in both arms. And then the usual kind of side effects that we see, but again, nothing new that's being reported by patients with TAF that there hasn't already been reported with TDF. So in terms of safety data, one thing that they remarked on in terms of the reason why the safety data might be better, as I mentioned at the beginning, that plasma levels of tenofovir in patients who take TAF are significantly lower, and these studies did show that. So there was a 91% reduction in circulating tenofovir levels in the TAF group, and you can see the mean area under the curve is significantly different. But the intracellular levels of tenofovir were significantly higher, actually 4 times higher in the TAF arm than the TDF arm, which prompted someone to comment actually in the audience about whether we could actually get away with using even a lower dose of TAF than the 25 milligrams. But that has not been studied, and that has not been studied in phase 1 or phase 2 trials. The renal endpoints, so there were no renal adverse events that led to discontinuation with TAF. So there were very small numbers in the TDF group, I'll say, though. There were 4 patients who dropped out due to renal toxicity versus 0 in the TAF group. But the proteinuria issue, there was significantly less proteinuria in patients with TAF, who received TAF, and they used 4 different markers. So proteinuria is measured by urine protein to creatinine ratio, percent change from baseline, very low, and actually improved potentially. Albumin, same thing. Retinol binding protein and beta-2 microglobulin, and I know we've brought these up in previous echo talks to when we're trying to identify tenofovir as the reason for someone's renal insufficiency or proteinuria. So these are markers of proximal tubular injury, And so both of these, as you can see, were significantly less in the tenofovir, the TAF arm compared to the TDF arm. So overall, looking very good in terms of renal toxicity. Again, this is in treatment-naive eGFR greater than 50, though. Bone results, there were no fragility fractures seen in the study. Again, this is 48-week data, so we wouldn't necessarily expect anything dramatic in that time period. But what they did note in the spine and hip DEXA scans is that there was a less effect on bone mineral density with TAF. In fact, in the hip evaluation that you see here, the purple line is barely deviating from the straight line, which is normal or no change. And the authors commented essentially that this is the lowest decrease that has ever been seen with NRTIs in patients who are receiving NRTIs in terms of bone mineral density scans. So TAF is not only better than TDF, but it seems to be potentially better than other drugs that we're using in terms of bone toxicity. Lipid results, not really statistically significant when you look at total cholesterol to HDL ratio, but you can see that there's actually lower values in the TDF group, although subtle in all of these, but they are statistically significant. And the authors comment that TDF actually has some lipid-lowering properties in and of itself that we're not seeing with TAF, and that probably has to do with higher circulating levels when you use TDF versus TAF. So conclusions about TAF. It is not inferior to TDF. 92% achieved virologic suppression, low rates of virologic failure. In terms of resistance that was seen in the patients that did develop resistance, only 6, they all had M184V, and 1 had, in addition to M184V, a K65R. There was favorable safety and tolerability data, and no discontinuation for renal toxicity, and very low discontinuation rates overall. Similar adverse effects reported in both arms, suggesting that there's not something new to be concerned about with TAF. But most importantly, less renal toxicity in terms of less decrease in eGFR, less proteinuria, less tubular proteinuria, and less impact on bone mineral density. What we don't know so far, although maybe not an issue because it's less plasma levels, is the drug-drug interactions. We assume that'd be pretty similar to TDF. And the role in Hep B and C co-infected patients. Hep B, there are ongoing studies to look at TAF for treatment of Hep B. We don't have that data yet. Hep C I put here not because it's a treatment for Hep C, but because they excluded Hep C co-infected patients in this study. Important to note. I will say that there was another abstract that was a poster presentation that was not an oral presentation that looked at switch from TDF to TAF in patients with mild renal insufficiency, and they did note improvement in renal insufficiency. And those patients were more middle-aged, 40 to 50-year-old patients was the mean age, as opposed to this one, which tended to be a younger group. Maybe some rationale going forward for the switch when it becomes available. So just switching to the cure slides that Dr. Harrington put together. There have been some not so great news about HIV vaccine in years past in terms of efficacy, sort of not where we want it to be in terms of a potent vaccine. So this group here who presented thought, well, we know that there are humans, they're rare, but there are humans who have chronic HIV infection that eventually produce potent neutralizing antibodies to a broad range of HIV isolates. Instead of trying to create a vaccine that basically tries to mimic these antibodies, the production of these antibodies, investigators thought, what if we just used these antibodies, created these antibodies, and bypassed the traditional vaccination route? And this is what they thought about doing. And this is what they've done so far in mice model and primate models. So they identify these rare HIV-positive individuals who make these broadly neutralizing antibodies. They isolate the antibody gene from their plasma cells. So just don't even worry about making a vaccine. Just get the gene, put it into a vector, which is an adeno-associated virus, and then inject it straight into a muscle and see if, and basically allow the muscle cells to make this broadly neutralizing antibody. So they did this antibody gene transfer in mice, and what you see here, they put in the vector, and they inject it into mice. And then what on the A panel just shows the muscle cells pre gene transfer. Post gene transfer, what you see is the stain is for the antibody. So the muscles are staining positive for the antibody. So what the muscles are doing is taking that gene and then producing the antibody. So you've made your muscle, you've just bypassed the immune system and using your muscles. So then they did this experiment in monkeys, and they looked at, they used control animals who were challenged with SIV, and then these immunized monkeys, so monkeys that were given through this vector, this gene, and intramuscularly to see if they would produce these same kind of antibodies. So all the unimmunized monkeys died of overwhelming viremia. The immunized monkeys were protected, and they have data more than 6 years out now that these monkeys are still making antibodies from their muscle. So next step, it's planned in humans, and a phase 1 trial looking at putting this vector in and seeing if muscles will make antibodies in humans. So stay tuned for that at future CROI meetings.